this is a lot of slides. There's too much. So what I'm going to try to do is make sure it's very narratively clear. Today, my topic is about spine augmentation after spine injury, mainly targeted towards things with osteoporosis. This is not the same as open spine surgery. If any of you or your friends are orthopedics, they know about this stuff. They may or may not do it. And hopefully this is something that can work hand in hand with the orthopods in trying to manage people with spine injuries. So why does this happen? I think we've all seen, and maybe we're all going through it, going from a nice straight spine, young and tall, and then there's this hump. We call this in medicine, and it's not very nice, the dowager hump. Is that a racist term? I don't know. I will ignore that. But suffice it to say, when we get older, if your bones become weak, they start to collapse, and this happens. So what does that look like? And this is a colorimetric scan. You can see that this vertebral body is partially collapsed, right? This is healthy. It's a box. It's almost a rectangle. But what can happen as we age is as it weakens, the front part of the spine, the vertebral body, will partially collapse, and it starts becoming angulated. So on a tissue level, this is what's going on. Your young bone, my young bone, I'm heading the same direction, used to be nice and thick, a honeycomb, a very thick calcium and phosphorus. It's the scaffold. It's spongy, and it does its job holding you straight, giving you mechanical strength and rigidity through your long bones, your spine, all your bones. This is what gives you form. As we age, the bone, if it's not healthy, starts thinning. And so all of those little honeycombs become thinner and thinner and thinner, and there's less material there to keep them with structure. What is this scale of the problem? Well, we're looking at probably more than this, 100 million people worldwide at risk. This is from 2002 data. 44 million in the US at risk. 1.5 million fragility fractures in the United States, 700,000 spine, 300,000 hip, 250,000 wrist, and 250,000 other. And if we don't do a good job of preserving bone density, this may actually become a bigger issue. And obviously, it's very nutritionally related. How much does this cost? Well, breast cancer, we spend, and again, this is old data from maybe 10 years ago, about $13 billion a year for breast cancer. And any of you that know Dr. Ueno, he's a breast cancer researcher, now the chief of Cancer Center here. So I can laugh with him about this. Heart disease is about $19 billion a year, but osteoporosis is actually staggering at $20 billion. You can think about why. Breast cancer might kill you, might not. Heart disease very well can kill you quite quickly. Osteoporosis probably won't kill you. It'll just make you maimed. You may not be able to walk around as well. You may not be able to function as well. You may not be able to carry what you used to carry. You can't help out in the house the way you used to. Osteoporosis can be very devastating because it results in infirmity and not mortality, if that makes any sense. There are exceptions, and we'll talk about that in a little bit. So back to 2002 data. We're looking at $17 billion of direct expenditures in nursing homes and hospitals related to osteoporosis, about $46 million daily. In 2030, they expect something like $164 million daily. Of course, this is before inflation, so I guess what, we're now going to be 2 times, 3 times this? Bad joke. So what does this look like a little more grossly? This is a cut of a spine. I got your back. And this is the fracture. So when you crush a spine, a vertebra, when it collapses, a couple things happen. One, when it heals, it's going to, and these are the discs between your vertebral body. So this is the collapsed, almost completely collapsed vertebral body. There's a little bit of residual marrow. That's what this stuff is. And if any of you guys like eating bone marrow, this is the human version. Don't eat this. This is illegal. But the bone marrow is crushed, and as you collapse more of this, you have less bone marrow. Mostly we don't see, anemia from this, but this actually is a major part of where you produce your blood cells and immune cells. and collapsing that certainly doesn't help. When we talk about osteoporotic fractures, it's often associated with minimal or no trauma. Basically, you're getting out of your seat, you're getting out of your car, you twist the wrong way, and because this bone is already weak, it collapses. It is the #1 cause of years lived with disability in the U.S. Again, about 550 to 750 vertebral fractures per year. There's 150,000 hospitalizations per year in the U.S., and mortality risks increases at 5 and 10 years due to vertebral fracture. We'll talk a little bit about the possible mechanisms. We project osteoporotic-related fractures to increase in both number and expense in the aging population. As you know, Hawaii has the longest lived Americans in the country. So unfortunately, that also means we're more likely to have more and more osteoporotic fractures as our population ages. You probably also know that osteoporosis is more likely in Asians and Caucasians. African Americans have the lowest, have higher bone density. So basically, in Hawaii, we're talking 99% of the population is at increased risk of osteoporosis. Spine fracture is typically 14 days of disability per fracture, and hip about 18 per fracture. So as much as you dread a hip fracture, a spine fracture is not that much better. So what is we talking about kyphosis? The medical term we talk about when you hunch forward is kyphosis. The opposite is lordosis, where your body is arched back. Lordosis we don't see very often. That's not a very typical pattern, and is beyond the scope of this talk. So in a normal spine, you should have the weight-bearing vertebra are carrying your upper torso and your head and putting that force onto your hips, onto your pelvis. When you start having a fracture, let's say you get in a car accident and now you've destabilized the ligaments because of all the trauma, what happens is you start leaning forward. And you can think about any of you that are in construction or engineering or build stuff, when you start having angulations, things become unstable. And it progresses because there's further abnormal stress on the spinal column. This is a slide I really like. In a normal, textbook normal person, you should have very minimal vector force pushing you forward and down. But once you've got a fracture, you can see how that changes the angles of force in your spine. And so as this continues to crush, there's increasing anterior force on your column. That's why you see vertebral compression fractures become angulated. And every angled fracture you have changes and worsens the stress on the anterior part of your vertebral bodies one by one. And that's why you go from nice, straight 20-year-old spine to the racist term, sorry, I shouldn't make those jokes, the dowager hump. I don't like that term, but basically you know it, you're completely arched over. Now, what else does that do? When you have, diagnosing vertebral compression fractures, it's not that hard. When you have someone, hopefully not you, hopefully not even your friend, but your friend's friend's friend has a vertebral compression fracture, they're going to just talk about having spine pain. It typically locates right over the bone. If you tap the bone there, they're going to hurt a ton. One of the things I do to see if they've got a back fracture is I might jostle their seat or their bed they're on. People hate it. They're like, ugh, it really hurts. And what we'll do is either get an X-ray of the bones. That's a simple way of doing it. MRI is what we really like because we may have old fractures that we don't know about, and the X-ray may not be obvious. On the MRI, we can see edema, active inflammation in the bone. We can see that on bone scans as well, a nuclear medicine scan. PET scan also can do that. So we have multiple scans that can confirm that indeed there is a fracture, and second of all, where it is. And then we can make plans on how to manage those things. So the three ways that we can try to approach a bone fracture like this: conservative, non-surgical. So insurance is happy generally because they don't spend very much money. They put you in a brace, and we'll show you pictures of that. They may tell you to stay in bed for a long time, and then as your bone heals and become sclerosed, which is to say the bone, your osteoclasts, the cells that are responsible for depositing the bone structure, they go into overtime, they scar down the bone, and that's why when you end up with a flat vertebral body, when it used to be a box and now it's a plate. The next thing they can do is what we're talking about today, a vertebral augmentation. What we use is needles to about a half a centimeter hole in your skin, and then we place a needle into the bone, and then we literally do construction work. We insert cement, medical grade cement, into the bone to stabilize the fracture and potentially restore height, and we'll show that in a little bit. Those are 3 examples there of techniques that we have in vertebral augmentation. And lastly, open surgery. If this is particularly useful if there's bone fragments that are now crushing the spinal cord. If the bone fragments are now pushing on your nerves, first of all, it can be painful, but more importantly, it can paralyze you. And so if there's injury to the cord, very frequently we start thinking about taking those fragments out with open surgery and restoring the space that protects your spinal cord. Fixation is, laminectomy is removing the bones to give space to your spinal cord, and fixation, they'll put in rods and screws to stabilize that joint. So this is more common with substantial numbers of fractures. The difficulty as we age is it's harder and harder to do major surgery. So as we age, there's a little more usage of these minimally invasive techniques that don't require quite as much direct tissue trauma. So this is an example of conservative management. So basically there are different types of braces that we use to try to stabilize your spine. So while you're moving around or getting up, you're no longer putting huge amounts of stress on the fractured fragment. Immobilization, braces, pain medications that we can give. The danger, of course, as you know, is lots of pain medications, the risks of addiction, constipation. Any of you that have taken opioids know that they're not a cure-all. And the other issue is when you're in the bed for a long time, you start losing muscle mass. It's a lot harder as we're older to maintain muscle mass, so there's a lot of decompensation and atrophy as older people are in the bed for a long time. Lastly, you're not moving around, so your veins don't move. It's more easy for you to clot, and the dreaded PE, when you form a clot, the clot goes to your lung, and God willing, we don't see anybody die from it, but it's a real concern that we have when people are immobile for a long time. Examples of braces. So the cause of fractures. If you have a spine fracture, decreased activity. You can't do the things you used to do. Increased rates of depression. We certainly see that in the literature. Lower self-esteem. You're now hunched over, you're fractured, you can't see your friends. It's tough. Increased anxiety, diminished social roles. You cannot help your family or your friends. Increased dependence. You need help rather than to give help. The other thing that very direct and anatomic, you actually breathe worse. How does this happen? When you're fractured and you start hunching over, you can imagine that starts crushing your chest. There's less space in your torso for your lungs to do their job. So the estimate is generally that one vertebral compression fracture loses you 9% of your lung volume. That sounds horrible. Any of you that are still running and doing athletics, doesn't that sound horrible? 9% of my lung capacity? So we can show this and through FVC and FEV1 are numbers pulmonologists use to describe how well the lung is functioning. So things that we can do. The vertebral augmentation is what I'm going to talk to you about today. So these are minimally invasive techniques to try to get people back on their feet faster, heal the bone faster. So what we're aiming for is reduction of pain and improved biomechanical stability. We're literally doing repair work. So we put in medical grade cement, again, through a big needle right into the bone. It has been shown to improve pain, prevent subsequent fractures of that level, and decrease morbidity or mortality compared to non-surgical treatments. How? By getting you back on your feet faster. What does this look like? So imagine this is your fractured bone. What we would do is drive a needle right into it, through this needle. The original technique was done in France, actually brought to the United States by the guy who taught me medicine, or this field. And what they would do is inject methyl methacrylate, a medical-grade cement, right into the bone. So this is what it might look like. This is a variation of it, where what we'll do is we use a balloon to open a space in the marrow, and then you fill the space with cement. So in the best case scenario, you see how compressed this is. You can lift the fracture fragments apart from each other and fill it with cement, and thereby improve maybe a centimeter or two of height. For those of you that are fearing, actually, I've got to tell you a funny story. My mom once was in a conversation with my brother. She says, as we get older, we lose height. And my brother at this time is like 6, so he starts crying, tearing up. He goes, Mom, why do you get smaller? Well, our bones compact and get crushed, and I'll get shorter. And he goes, then he starts really crying, and he goes, does that mean you'll shrink and disappear? Fortunately, fortunately that doesn't occur. All right, so this is an example of a kyphoplasty, and the reason why you use the word kyphoplasty and not vertebroplasty describes just putting cement into the vertebral body, into the bone. Kyphoplasty was designed with the intent of improving the vertebral body height. So taking a crushed box, opening the box up, and then restoring the height. So in this case, what they do, you see this crushed, this very flattened vertebral body. We put a balloon in. This is the balloon catheter. You inflate the balloon, and you try to pry the end plates apart, and then you fill that space with cement, and you try to improve the height. This works best when the fractures are young. If they've been there for a couple months, typically there's healing, and which is to say fusion, and then it becomes a solid bone. This does not work very well. So I'm going to skip these. This is mortality after hip and vertebral fractures. I think all of you know that hip fractures are scary. Anyway, I was going to make a Kasanaka Sone joke, but I'm not going to do that. So if you have a hip fracture, if general population, this is the mortality curve, how frequently people die, it's just survival, unfortunately. Hip fractures do this. Vertebral fractures have this line. Hip fractures are more mortal, that line. But it's not that much nicer than a hip fracture. Men, this is the typical Kaplan-Meier, the survival curve that we see after fractures. So I think the message from these slides is don't get fractures. Women with vertebral fractures have a 5-fold increase of new vertebral fracture and 2-fold increased risk of hip fracture. There's a couple reasons why this occurs, right? If you have fractures, that probably means you already have osteoporosis. So there's that association. But also, once you fracture, you're no longer moving normally. You may be staggering, your muscles are tightened to try to protect yourself from abnormal movement. So you're actually placing abnormally high strain on bones that aren't used to it. And your bones already are weak, and you're doing abnormal things to them. That's why this cycle of destruction kind of accelerates. One of women who suffer a vertebral fracture, 1 in 5 will suffer another vertebral fracture within a year. These is 2000 data, and these days it's hot to talk about fragility indices. Point is that as we get older, we get more fragile. So everybody in the room, myself included, my wife included, she came with me. You have to protect your bones, you have to eat calcium, get sunlight. We're in Hawaii, so that's good. Vitamin D, we can talk about that later, but protecting bone density is essential. I'll skip this one. The patient selection. So how do we choose who we want to do vertebral augmentation? We want patients with symptoms. You don't want to portray a picture. You want a positive MRI. We see that we know where the fracture is. We know that it's recent. We know it's causing pain. And the things that we're aiming for is stopping the pain or reducing the pain. 1. 2, reducing height loss, because that has impacts too. It's not just cosmetic. There's also respiratory impacts, and there is biomechanical impacts from losing spinal height. And lastly, and we just treated somebody like this 2 weeks ago, they're stuck in the hospital for a couple weeks potentially, or in nursing care because you have this painful spine fracture. Sometimes we can get patients back on their feet within a day, right after the procedure. So that's why that's very important to us, reduce atrophy, reduce the likelihood of DVTs. Skip this. What do we normally do? Post-procedure, we typically discharge the patient same day, same afternoon. Follow up within a week in person, by telephone, and then a clinic visit in 2 to 3 months. We do recommend patients after this to be careful with how much weight they bear, because now you have a rock as one of your vertebral body, because I just gave you medical grade cement. The rest of your vertebral body haven't changed, which means they're still maybe pretty weak. And so we generally encourage to speaking with a geriatrician or your primary care physician aimed at improving bone mineralization to prevent the next fracture. Also, it's probably a good idea during that time, because you're splinting and your movements are abnormal, to avoid heavy activities, because those things can fracture other vertebrae. And lastly, I guess combination of anti-resorptive. This is medical jargon. We want to avoid your cells that break down bone from doing too much, and we want to encourage the cells that drop bone off and construct bone to be in overdrive. So this is an example. This is a 94-year-old male with a history of osteoporosis, previous left hip replacement after fall in the nursing home, has a new T11, it's a vertebral body near your diaphragm with a 20% height loss. Old fractures are present, 10 out of 10 back pain, taking pain medicine but not sufficient pain control. So this is what it looks like. This is the old fracture. You can see this is that wedge that we talk about. This is an old fracture. This is the new fracture. You can see that there's edema. This is MRI, and we see this bright stuff. It's fluid in the bone marrow, and that's the one that we are going to target. There's another old fracture right below it. This is T12, this is T11, the new fracture. We'll then drive a needle into that area. This is a kyphoplasty technique, so they opened up a balloon, then infuse the cement in, and voila, T11 fracture is now treated. 1 week post-procedure, pain is minimal, 2 out of 10 at worst, off pain medications, ambulating with a walker. So he's much less likely to have the DVT, much less likely to have adjacent, loss of height that has all of the other things that we talked about. This is, of course, best case, good case. This is another device that we are working with. It's called the spine jack, and it looks just like a car jack. I wonder where they got the idea. So the difference in this is what we do is we put 2 of those needles, big needles, into the vertebral body, and then we jack it up. It's really complicated, right? This does not take a medical degree. And so what we do is we use these screws, and that just screws open the jack, and these skis are designed to hit the end plates of your vertebral body, and it opens the box up. We published a paper last year. There's several papers from Europe. We published one from Hopkins 2 years ago, just showing that this kyphoplasty with the spine jack is much more effective at restoring height than the other techniques. It's very, very obvious. It's much more effective. And so we will use this. We do not use this with cancer patients. We just think that this runs into too many problems if you're doing this in a metastatic fracture. But in terms of patients with routine kyphotic fractures, this may be a way to restore height immediately and improve the compromise of the chest. Other things that we can do, we can't do cancer. So in limited situations, what we can do is drive a needle with a temperature agent to burn tumors where they are. This is useful when we have a limited number of tumors in spines that for some reason the radiation oncologist or surgical oncologist don't think they're a good candidate for those treatments. So we can bring in either a ice ball, cryoablation, radioablation, which is using electromagnetic waves, and microwave. Those are the 3 techniques we use right now to locally treat tumors using needles. And then after that, because you destroy the tumor and there's some damage to the bone, we then replace that space with cement. So this is another thing that we can do with a similar technique. And you can see a much nastier tumor, And so we would ablate the tumor using one of those above techniques and then fill the tumor site with cement to restore. And we will use this sometimes in preparation for radiation therapy. Sometimes somebody has a really painful metastatic spine tumor, and it's very hard to lay still inside the radiation machine. And so we will treat them with this, and that reduces pain, and then they can go on and get their radiation therapy. Last thing I want to talk to you about is sacral fractures. We need to do more. In my opinion, we need to do more in Hawaii. I understand that we basically don't do them for the state. When you have a sacral fracture, it's like the worst version of a spine fracture. What happens as you have osteoporosis in your pelvis is one day somebody might get up, stand up, and their bone in their pelvis gives out. And then you have an H-shaped fracture right through the sacrum. It has a high mortality rate because people can't stand up when you have a sacral fracture. Prolonged bed rest can result in decompensation. It's estimated to have an 18% mortality. So not too much better than a hip fracture. So this is what it looks like. This is the sacrum. And these step-offs, this should be a smooth, bony step-off between bones. And instead, you see this, the bone is no longer connected. Through this area is where the fracture plane is through the sacrum. And typically, people will be weeks to months in bed. Now, surgeons can put screws into the pelvis to fix them and put them back together, but it's a tough procedure, and I defer to my orthopedic colleagues if they get mad at me for saying this. I apologize to them in advance, but I don't think in general they like doing these for people in their 70s, 80s, 90s. It's a lot of surgery. So what we can do is put those tubes right into the fracture site, and then we fill it with cement, fuse the bony fractures, and this is one that I did at Hopkins maybe 4 years ago. And this is the final images of the cement in the sacrum, and she was able to stand later that day. It's not pain-free, but she goes from not able to stand in a day. That's why I think it's a very important thing for geriatrics and family medical doctors to know. If this happens to your patient, send him to us. We can get him standing. So what does this look like? Pain scales, VAS and ODI are scales in terms of function and stability. This is right before the procedure. This is right after. And in this analysis, you just see an immediate improvement in function. And that's what we see. Obviously, nothing's without complication. Nothing's ever perfect. But the vast majority of sacroplasties we do, people are up and about very quickly. This is a review of 19 studies on sacroplasty. 95% clinical success. Complication rate was 0.3%. Improvement of pain of up to 12 months, and it stops because they never pay enough in studies to keep on studying after 12 months. I shouldn't say that. Sometimes it's longer, but and so osteoporosis, malignancy, and non-specific causes were included in the study, and basically it's a good procedure. So to summarize, debilitating back pain and limited mobility from spine fractures and sacral fractures is a large and growing problem for us, especially as we live longer and longer. Vertebral augmentation is a low-risk and minimally invasive procedure that can reduce pain, improve mobility more quickly, and prevent subsequent fracture at that site. Along with that, however, once we treat those fractures, all attention is back to bone health. Try to prevent further osteoporosis, try to reverse osteoporosis, try to prevent further fractures. Cheesy, bone health matters. Support bone health because bones support you. Thank you very much.
Thank you so much, Ferd. That was a wonderful presentation. We already have a few questions from our online audience, but Aaron is taking the mic around. Oh, Virginia has a question right here.
Well, like your mother said, most of us lose height as we age. And does that increase our risk of vertebral fracture?
In a sense, there's several things going on with your vertebral bodies. One, in a sense, they're microfracturing and shrinking. The other part where you lose height is your discs. The spaces in between your vertebral bodies are a cushion. They're called, excuse me. And so that area also loses height over time. These are areas that we still don't have great answers for. There are prosthetics that we can put in for the discs to try to improve the cushioning as well as restore some height, but they're very invasive procedures. They're probably not quite ready for prime time. But yeah, that's really where you're losing the height. Microfractures and compression of the vertebral bodies and loss of the interspaces between the spinal vertebral bodies.
We have some questions from our online audience. The first one is, does vertebral augmentation fuse the vertebra together?
No.
Or does the cement affect only one vertebra?
We can do multiple vertebral bodies. The most I've done at a time is 6 for somebody with multiple fractures at the same time. But the bone, when properly done, the cement should only be in the vertebral body one at a time, and then we would just access additional bones as needed if they were fractured.
Okay, thank you.
I wondered if this procedure helps at all with scoliosis.
Scoliosis, probably not, because in the end, if you have scoliosis, you have had it, your bones are actually shaped off. You know, it's not a rectangle, it's a trapezoid. And so you'd need to fracture the bone to try to improve, to make it a square again. So this is really not well designed for scoliosis. Scoliosis at this point, there are things that can be done while children, scoliosis, to try to correct posture and correct the limb length discrepancies. Is actually one of the most common ones. If one of your legs is slightly longer than the other one, the body doesn't grow correctly because your pelvis is compensating for the difference in your leg height. So if you intervene very early, there are ways of trying to prevent scoliosis from getting very severe. There are other types of diseases that result in scoliosis at that age. But once your skeleton is mature, really it's going to require surgery with rods to try to realign the spine. At this point, at least, I'm not an orthopod. I'm not aware of any other techniques that can be done for that. This will not fix scoliosis.
The next online question, how many vertebrae are typically treated with cement? Is there a limit in the number? Because if you treat a lot, will it cause fractures in other vertebrae?
Excellent question. As we talked about earlier, when you cement a vertebral body, it becomes a rock. It's stronger than your own bone. And therefore, the stress on your spine has to be dissipated, right? It's on your intervertebral discs and on each of the vertebral bodies. So the more, and this is true with spine surgery. Again, don't tell any orthopods in this room. Okay, it's safe. I can talk. If you fused 6 levels, the levels below your fusion has way abnormal stress, right? That doesn't take a lot of imagination. Because now, say, this part of your spine doesn't move. So you lean over, it moves like this, which means all the stress is right here. And this is true for everything that we do to fix spines. So when we fuse a bunch of these, let's say we do a lot of vertebral augmentations and now we've cemented, say, 5 levels, those won't fracture again if they've been done well. And so all stress to the spine will be distributed to the others. So that's why it's really important when we do such procedures to really go for the root problem, which is the osteoporosis.
Two questions, but the first one is more clarification. About the height loss, that's because we have fractures that occur that we're not aware of?
Yeah, I mean, in the end, there's microfractures and micro-remodeling, right? Your bones are alive, and there's just like you're always bleeding somewhere, except you're stopping your bleeding and you don't notice it. And the micro-injury, micro-trauma to your bones, those things are remodeling over time. So you'll see that older people, they typically have slightly wedge-shaped vertebral bodies. Young people, nice and big, juicy boxes. And that's part of that remodeling over time, which is probably related to micro trauma and micro remodeling over time.
So are there elderly people who don't lose height? And if that's the case, is it,
I think the only way you're not going to lose height is if you are only in the water with no weight bearing. It's not going to happen. Okay. We live on land. So yeah, you're always going to be compressing your spine because you carry your weight, and that's.
Okay, then the Dowager hump, which I remember that from like Downton Abbey, right? She was the Dowager Miss Crawley. That's the way she was. But anyway.
What is a weekend?
Yeah, that was good. Yeah. Is that caused? Again, what causes that?
So
is that from the fractures?
Multiple microfractures resulting, and sometimes it's just, you may not know you fractured a vertebral body if it's just kind of, so like that guy that I showed, old fractures, he may not be aware he fractured them, but now they're pancakes. And once they're pancakes, you go from this to maybe, and then the next one, and then the next one. And so, and as I showed you that diagram, the more kyphosis you have, the worse your stresses become. I didn't put this in this slide, but one of my good friends is the chair of neurosurgery at Cleveland Clinic. When I was there, he said, kyphosis begets kyphosis. The more angulation you have, the more it stresses your bodies and forces that to happen. That's why the Dowager hump occurs. If you see Granny's spine, it'll be all bunch of pancakes, all of them wedges. And so it's like a train tracks that are, the curve in a train track. That's what it'll look like.
So it's not a matter of bad posture?
Well, it's all of the above, because when you have bad posture, what does that do to your spine? It's the compression on your spine is all at the front, right? It's a rectangle. And if you have bad posture, you're probably thinking of your kids and stuff. The bad posture means more stress here, and over time it'll compress. And so it's a ongoing process where when you have bad posture, you're going to have the tendency to hump and more stress on the anterior part, the front part of your vertebral body. If they fracture, that's going to make things worse. If another fracture, it's a cumulative process.
Okay. You see that like in Japan with farmers, planting rice in the old days by hand, and
yes,
and that's why, I guess. Okay.
Yeah.
Thanks.
I'm certainly trying to stand a little straighter after this talk. I don't stand very straight, and I'm getting very self-conscious now. Yeah, okay. The next question is, what sham procedures are used to treat osteoporotic vertebral fractures?
Oh, somebody read the slides. So there was a paper, and actually this paper was by the guy who got me into this field when I was at UVA. He's now the chief of neurointervention at Mayo Clinic. So Dave Collins' group proposed a procedure where they would do a sham procedure versus a real vertebral augmentation. You wouldn't tell the patient what happened, and then you judged and saw what they did. This was published in 2009, I believe. And what they did was they just made little cuts in your back and didn't do anything else. So and this is really weird. The first sham procedure study was joint arthroplasty, and they did a real arthroplasty versus a sham arthroplasty. So they actually put the person in a chair, put a curtain, the real arthroplasty on for some patients, and the other ones they played sounds of surgery and made little cuts on their knee, and there was very little difference between the two groups. So don't tell the orthopods that. But the same thing happened in this study, the 2009 vertebroplasty. There wasn't very much benefit for vertebroplasty. The criticisms of the study were they didn't use very good metrics to try to figure out whether the patients improved. And so that's where the subsequent studies that I mentioned, including the FREE study, did show benefit of vertebroplasty over nothing. But during the 3 years after my mentor published that study, vertebroplasty procedures went like this. They're like, nobody doing them. They're like, ugh. And so insurance companies now pay for vertebroplasty if patients have osteoporosis or cancer. They won't pay for young people that fracture their spine. So if you have a 22-year-old friend who fell off a horse and fractured, they won't pay for that. But they will definitely pay for patients that have osteoporosis or a cancerous growth that has fractured.
I have a question or comment regarding the fracture to the spine. I've lost about 2 inches in my height in the last 5 years, and my doctor I was playing tennis, and my doctor told me it's degenerative disc space, not to run around and not to jump around. So that inhibited my tennis playing.
So it's a balance of all things, right? Because if you don't exercise, you'll decompensate and not do well. And frankly, part of preserving your muscle strength, your bone strength is activity. The grips, Kamal knows this much better than me, but all these little things that you do help reduce sarcopenia or atrophy of your muscles. So I would never tell people you have to stop exercising. The question, though, is what can you do to try to preserve disc height and vertebral body height? And the answer, in my mind, at least current medical science, is you need to support your bone health with eating the right stuff, getting the medications to improve bone deposition. And for your discs, we don't have great stuff. I guess if you want to be Asian about it, we're going to start eating a lot of cartilage. Cartilages and tendons, right? That's what my wife likes eating. But there are definitely people that think about this, how to restore disc space or at least preserve it. It's not ready for prime time.
Can you do an MRI if you already have metal inside from a former hip replacement? If not, what then? Not totally related to your topic.
No, that's fine. Okay. I know why they're thinking about it. The answer depends on the implant. Most things we put in today are MRI safe because MRI is generally the best imaging we've got. But if your implant is from the 60s or 70s, it may not be MRI compatible. So the big thing for you is to find out what was put in. If it's recent, it's almost always MRI compatible. If it's been decades, you need to find out.
I wondered what your thoughts are on the drug Prolia if someone has osteoporosis, and if they are taking Prolia, if any of these procedures are possible or if they're not compatible.
It's not a compatibility issue. I would just say everybody who has osteoporosis needs to treat their osteoporosis. That is, and I think it'll take longer amounts of time for us to understand how effective the drugs are and if the complications, side effects are worth the drug, and that I'm sure that there'll be more coming from geriatrics in the future. But if you have a fracture and you're on the drugs, this is a mechanical solution, so there is no reason why you can't get this type of surgery when you're on the drugs. In fact, after the surgeries, we would tell you, you need to be on something to improve your bone strength. Prolia might be one of them.
Thank you.
30 years ago, I had 4 levels in my neck fused. They took bone out of my hip and pounded it into my neck. Today, would you use concrete instead?
Without seeing the images, it's very hard for me to tell you. But it really depends on why they did the procedures. Most likely, what they were treating was narrowings in your spinal canal. And so what they probably did was fused the level and took out bones that were pressing on the spinal cord. And what they'll do to make sure there's still protection for your spinal cord is take bones from your hip or somewhere else and pound that, as you said. That's a beautiful and kind of terrifying image into this to create armor. And we used to use those techniques in scoliosis patients as well. Once you realign everything, they'll take bone chips and try to create a new armor for you to protect your spine from impact. So the answer, though, is the percutaneous approach is really designed to strengthen the actual bone. It will not, right now we don't have techniques that would take care of the narrowing. So most likely, in your case, if your surgery was done for a typical reason that you're describing, no, a vertebroplasty wouldn't have been a good option.
There are several people who are asking about treatment of osteoporosis, which is not quite the topic of your talk.
Do it.
But,
All the time.
At what point do you recommend it? What is the best treatment, etc.? There are a whole bunch of questions.
I think,
about
Kamal, you have a clinic for this, right?
Yeah, so I think if you're concerned about osteoporosis, I would definitely recommend you talk to your primary care physician, and if necessary, they will refer you to a specialist if they have questions.
I'm going to make a pitch, crazy pitch, and I apologize if this sounds too pecuniary, but we're in Hawaii. We live long. We need to invest in longevity medicine, and I'll tell you, the insurance companies and the CMS, Medicare, don't really understand longevity. So if you can talk to your congressman and blah, 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 let's fund healthy aging. We have to do it. This room is full of people who want to age healthily. I want to age healthy. My dad just made 83. My mom's 79. I think about it all the time.
Yeah, thank you. This is a very interesting question. When do we go from young to adult to aging, elderly, old? Can't we come up with a better all-encompassing term like previously young? I like that.
I see a TED talk for this person.
Yeah, I agree. Are there any more questions?
I was curious about, years ago they were recommending Fosamax as a treatment for osteoporosis, and it caused jaw necrosis. Are any of the others causing that as well?
Yes, this is where I'm going to defer to my friends that are in bone health directly. Again, I'm more of a brain plumber, but talk to your PCP. I assume somebody in geriatrics has a specialization in bone mineralization, so Dr. Masaki will know the best on the island.
Yeah, I definitely think you need to talk to your PCP. It's different for different people. The length of treatment makes a difference. So it's not a cookie cutter, one treatment for all. It sounds like maybe this is a good topic for next year, though.
Maybe on the same day.
Maybe.
I just have a quick question. This procedure, when you put the cement inside the vertebra, does it reduce the flexibility of your spine?
No.
Oh.
So ideally, at least when properly done, if there are no complications, what it should be doing is all the cement is in your bone, inside the confines of your bone. The cortex of the bone is fractured. What it should do is stay inside that box. And the issues that people will have with flexibility, so the complications that can occur, let's say the cement leaks out and goes into the disc space. That can hurt, and that can change stability. There are some people that will put cement, and this is not the on-label version, but people, when I mean on-label, the FDA-approved version, but some people have actually intentionally put cement in the disc spaces to increase height. But the downside of that is that's cement and not squishy hyaline. So it's controversial, but there are people that do that.
Are there places in Hawaii that offer this procedure?
Funny you should ask. No, the interventional, there are some orthopods that will do it. If anybody needs to see me, or I obviously do it, and my partners at Queens do it. But if you or one of your family, friends need such a thing, just reach out through the alumni network of the mini medical school, and we can take care of them.
Are there any more questions? Okay, that was a lot of questions. Thank you, Ferd, for your patience.